This episode of Cell and Gene the podcast is brought to you in partnership with Thermo Fisher Scientific. Thermo Fisher's cell therapy processing instruments are designed to help customers transition from process development to commercial manufacturing, utilized as standalone devices or integrated as part of a closed modular process. Thermo Fisher Scientific recommends Gibco CTS DynaSelect Magnetic Separation System, which is a next-gen cell isolation and activation instrument. Gibco CTS Xenon Electroporation System allows customers full control to optimize for a variety of cell types and payloads. And Gibco CTS Rotea Counterflow Centrifugation System is a closed cell processing system supporting a broad range of protocols for cell separation, washing, and concentration. Customers can rely on and streamline their drug development process with Applied Biosystems QualTrack qPCR and dPCR quality control tools for robust and reliable genetic analysis across various phases of drug development, supported by relevant, compliant documentation. Hello, listeners, and welcome to this episode of Cell and Gene the podcast. I'm your host, Erin Harris, and my guest for this episode is Pascal Touchon, President and CEO of Atara Bio, a biopharmaceutical company specializing in T-cell immunotherapy. Pascal, welcome to Cell and Gene the podcast. Thank you for your time.
Thank you, Erin. Pleasure to be with you today.
Good. All right. Well, last December, it was announced that Atara Biotherapeutics Ebvallo received European Commission approval as the first ever therapy for adults and children with EBV plus PTLD, and it represents the first approval of an allogeneic T-cell immunotherapy ever globally. So first of all, congratulations. That's wonderful and fantastic news. And a tremendous step forward in cell and gene therapy and medicine in general. So briefly talk us through the most important benchmarks that got Atara over the finish line to approval.
Now, thank you for your question there. It's indeed a landmark approval because cell therapy is relatively new as a modality of treatment, not new in terms of research, in terms of development, but new in terms of getting through the final step of approval in a significant type of geographies and then access to patients. If you think about it, it all started just a few years ago, back in 2017, when the first ever CAR-T Kymriah was approved in the US, followed by others in the US and elsewhere in the world. So just like 6 years ago now, 5 years and a half ago. So relatively short period of time if you think about the development of therapies in different type of disease. Now, this landmark came from a lot of work that started in an academic team back in New York at MSKCC nearly 20 years ago, where physicians were confronted to the challenge of addressing patients with post-transplant lymphoma. This disease called PTLD, or post-transplant lymphoproliferative disorder, is a relatively rare incidence of the disease, but very severe, rapidly progressing and deadly disease. This cancer is one of the most deadliest one that exists because the current life expectancy or median life expectancy of patients with that disease, when they don't respond to the first line treatment, it is just a few weeks to a few months. So very short indeed. That means half of the patient will die within a few weeks to a few months, and most of the other will die within 2 years. Because survival at 2 years is usually only about 10% at max. So these physicians were confronted to that particular challenge and were trying to find a way to boost the immune system in giving allogeneic T cells, so T cells coming from donor-derived T cells, because of course the patient is in that situation because his immune system is not able to really address the exacerbation of EBV infection in their B cells. And that's why the only way was to say, can we look at T cells coming from unhealthy donors that could be used in that patient to boost his immune system? And it took a long time to really create a product that could be sufficiently safe and effective to get some exciting clinical data. Then in 2015, Atara licensed that technology from MSKCC and transformed what was an academic idea and product into something that could go through phase 3 development and therefore pivotal study and go through filing and approval to access more patients. And that's what our team at Atara has done for now a number of years in a very effective way, because these products are extremely complex in the sense that they are products that are made of cells. We are giving about 70 to 140 million cells per patient when we treat them. And that means we have not only many cells in the final product, but each cell by definition is different. And if you think that about one cell is having about 42 million proteins, that gives you an idea of the complexity of the type of product we are developing. So that's why it's taking time, but we made huge progress in our ability to make a product that is of high quality, that is guaranteed to be safe and effective, and a product that could be used in patients across the globe once we get the approval. We've done clinical study, and particularly a study called the ALLELE study, that is a pivotal study. That study, which has been conducted in Europe, in the US, in Australia, and Canada, has enabled us to have data that could be presented to regulatory authorities and allow for filing and, in the case of EMA, approval of the product. Now, these data are quite exciting, and we presented an update of the study results at the recent ASH meeting, ASH Congress in December 22, where we were able to show that in this type of patients that are either refractory or relapsing after first-line treatment, the level of responders is over 50%. The time to response is very short, which is important because that's an oncologic emergency. You need to make sure that if your product is effective, it acts fast. And the median time to response is just 1 month. So you have about more than half of the patients are responding. They're responding rapidly, which is very important. And then when they respond, they survive longer. And in fact, in that particular study, we had an overall survival in total about 61% at 1 year. But more importantly, the responders have an overall survival of 84% at 1 year, compared with non-responders at 34%. What this means that when you have half of the patient responding, these patients are going to survive long term. And in fact, we had other studies we presented at ASH last year in 21, which shows from previous studies that were done by MSKCC in particular, and even ourselves, that the patients that are being treated when they're following for a long time, they have a very high level of survival. For example, at 2 years, we have more than 80% of the patients surviving. So that really shows how the responders, whether they are in complete response or partial response, are able to get the benefit of that therapy in terms of long-term survival, again, in a disease where, unfortunately, if they don't get that type of treatment, the life expectancy is very short. Now, that's how we develop. We licensed that, we developed that as a real product. We made a phase 3 pivotal study that could allow us to file with the EMA. And we had a very collaborative type of discussion with the agency where they were really keen to get that type of treatment through the system approved, in a sense that we are addressing an ultra-rare disease that is very deadly with a very rapid progression. And there is the impossibility in that case to do a typical development program where you're going to follow hundreds and hundreds of patients in double-blind way. You've got to act fast, but the consistency and coherence of the clinical results across our development were very important to convince the regulatory authorities that on top of a pivotal study, we have sufficient clinical experience to really confirm the efficacy, the safety, and the quality of the product that now has been approved under the name of Ebvallo. Now, maybe one thing is important to have in mind is that we had a pivotal study with only 43 patients at this stage because it's an ultra-rare disease. But in total, our experience with the product is more than 400 patients and over 20 years, as I said earlier, which means that again, the coherence, the consistency, of the clinical results in terms of efficacy, safety of the product is what was very convincing for the regulatory authorities. Now, this is something important because in an allogeneic type of situation, What it means that we have a product approved that for the first time as a cell therapy means that the batches we are manufacturing can treat many patients, hundreds of patients. And that makes a big difference compared with autologous therapy. Now, the product is now approved and being launched in Europe by your partner, PFAB. We'll talk about that later. But it's a great achievement for not only the physicians that started very early, not only the patient that participated in the studies, but of course the Atara team and the field of allogeneic therapy and in particular cell therapy.
Yeah, absolutely. And thank you for that well thought out and detailed background of what led us to the actual approval. That's really helpful to understand. And speaking of, okay, we have the first allogeneic approved therapy. What does that approval mean for the broader field of cell and gene therapy, not only in Europe, but really for the rest of the world, here in America, or, just in terms of the field in general? What does this approval really do for the whole sector?
Yeah. We believe it's a great progress for the whole sector, and I'll tell you why. If you think about cell therapy, especially in oncology, it all started with Carl June and his team at UPenn, who started to treat the patients. And the famous Emily Whitehead, this young girl that was treated back in 2012, has last year celebrated 10 years without cancer. So an amazing human journey for the patient, for the physicians that created this type of ideas. And of course, the UPenn team is not the only team that worked on these ideas. The Michel Sadler and MSKCC and others have also developed this type of approach to treatment of cancer. But it's just 10 years ago that the first patients were treated. It's now just, I say, a bit more than 5 years ago that the first product was approved. Since then, there have been 6 autologous CAR-T approved in the US and in Europe to treat some blood tumors, some liquid tumors, be it leukemia, lymphoma, or multiple myeloma, with great success. And these treatments are now available for patients, and they are really a great progress because they allow to not only to treat, but to treat with a curative intent, to have the ability to think about curing cancer in these patients. Now, despite all of this progress, the number of patients that can access this therapy is very limited. Even in the US, if you think about it, today, even with the approval of this product, only a minority of the patients that are eligible for an autologous CAR-T gets it. And if you think about lymphoma and DLBCL in particular, only about 40% at max will have a complete remission at 6 months, which means that 60% of the patients that have access to this autologous CAR-T therapy do not respond in a satisfactory way. So the unmet medical need is immense in terms of accessing more patients, in terms of developing better way of product. And here, why allogeneic cell therapy is so important, because the ability to have not on an autologous therapy where you start to extract cells from the patient, to transform these cells and back to the same patient, but you take cells from healthy donors, or you have an iPSC cell line, and then you manufacture cells, and you manufacture cells in a way that you can make many batches, from one batch, many doses for many patients. And we today, for example, with Tab-cel, we can make up to 400 vials and more per batch. So that allows you to have many ways to treat the patient from one batch, and hence to have also this product as an inventory of product that is available when a patient needs that. And one of the key issues with autologous CAR-T has been really the fact that there is a waiting time before the treatment can be to the patients, because you need to manufacture the treatment. And even with progress on manufacturing, this is really taking too much time. Whereas with allogeneic T-cell therapy, you can get the product at the patient very rapidly. In fact, with Tab-cel, our first product, we have now experienced that we can deliver within 3 days to the institution where the patient is being treated. So within 3 days, the patient can be treated from the time we receive the request from the physicians. So that type of speed is essential in many of these cancers. So as I say, the field has moved from academic experience and great results by very amazing pioneer in the field to making product that could be approved, but they were all autologous product. Now we're moving to allogeneic product that will allow a better access to patients. On top of better access to patients, this allogeneic product allows to make different type of modification to the construct that can improve the efficacy, the safety, and in particularly looking at durability of remission, which is something very important in cancer, because these treatments are not just developed to treat and to have some results for a few weeks or a few months. They are developed to try to have a curative intent, to be able to cure cancer. And that's why all the different features of this allogeneic T-cell therapy or other type of cells are going to be really implemented into the manufacturing of the product to get to this high level of efficacy, safety, durability of remission, and of course, done in a very high quality way, so it can go through the scrutiny of the regulatory agencies. Having the first ever allogeneic T-cell therapy, Ebvallo, from Atara approved through the EMA, is really helping the field to show the way that it is possible to get this product into regulatory approval, and it is possible to make them in a commercial setting. Now, on top of that, this type of allogeneic T-cell therapy will bring more profitability to the system because it's much less costly to manufacture for one patient than it is when you have one patient, one batch.
Yeah, sure. That makes a lot of sense. And I do want to talk a little bit more about one patient, one batch, so autologous CAR T-cell therapy. And I want to talk a little bit about, you mentioned earlier Kymriah, and you spent time with Novartis, and you played a pivotal role in the approval of Kymriah, which, as we all know, is the first approved autologous CAR T-cell therapy. I'd like to hear from your own words. What was your role, and how are you? What was your role with Novartis in involving that approval of Kymriah, and then how are you leveraging that expertise at Atara for the allogeneic T-cell therapies?
Yeah, my role was to be part of the team that got Kymriah approved and then launched across the world. In the later years, I was leading all the activities on CAR T for oncology in Novartis, which is developing Kymriah and other products, and also bringing them to patients across the globe. We got approval not only in the US after the first approval in August 2017, but then in other indications in Europe, in Japan, in Australia, in Canada, across the globe. And the idea has always been to try to expand the access to patients as early as possible, because we know and we knew at the time already that these therapies were really life-saving therapies. And especially the first indication was very emotional, I would say, for everyone working at Novartis or with the physicians and the patients and family of patients, because it was around pediatric leukemia and relapsed refractory pediatric leukemia. So we knew, and that was a key motivation for everyone working at Novartis, that the faster we go, the more we can save kids that could die because they are refractory relapsing through the chemotherapy first-line treatment there. So that was really a true motivation for everyone, and certainly for me, to bring that type of product as rapidly as possible to the patients. Now, the key lessons that is very useful for what we're doing at Atara right now is around the ability to convince regulatory authorities in particular that they have to accept what is inherent to cell therapy, and which is the variability of the product. As I said earlier, we are giving millions of cells to these patients. These cells have different type of characteristic, phenotype, and others. And then these cells are made of millions and millions of proteins. So the variability of the system is much more important than it is, of course, with a small molecule, but also with a biologic. And it's in collaboration with regulatory authorities that you can then align on what will make a proper quality control, a proper process control, a proper release specification of this product. It cannot be applying the small molecule model or even the large molecule like monoclonal antibodies model to that. It's taking time, but the experience with Kymriah told us that the FDA or EMA and other regulatory authorities, when they think about, one hand, the patient's needs, and when they think innovation and being themselves innovative in the way they look at this product, they can get through and they can approve this type of therapy that can save lives. And time is the essence there. Because again, I was saying about the motivation of Novartis and the physicians to get Kymriah and other CAR-T approved as rapidly as possible, because we knew that it could save lives. But the same now is applying to Ebvallo, to tabelecleucel, because we know this product can save a lot of life. We know, for example, in the US, there are many American patients today that do not have access to this product. We have only clinical studies and compassionate use, and therefore have no hope and no chance to possibly respond to such a treatment and possibly have long-term survival, if not cure. So that's really what is the motivation. And that's the learning from the Kymriah experience is we need to go fast. We need to convince the regulatory authorities to find the appropriate balance of scrutiny and understanding of what is an innovation like an allogeneic T-cell therapy, so we can get through and launch this product so we can access more patients.
Yeah, okay, good. I want to spend a little bit of time talking more about EBV positive PTLD. Talk us through where we're at and how an immune system that isn't working properly may result in EBV causing all sorts of issues. For example, the connection, if you could talk us through the connection, for example, from or between EBV and serious diseases like multiple sclerosis or MS.
So EBV or Epstein-Barr virus is part of the family of herpes virus that have been for millions of years now infecting human beings and even our ancestors. And the reason is there have been some kind of amazing situation where the infection is something that is ubiquitous. But then once you get infected, and EBV is a good example here, when you get infected, your immune system is able to control the infection, but not to get rid of the virus. There are many viruses where you get it. If you get a flu virus, you can get rid of it after some time. EBV, you cannot get rid of that. And what's happening then is that most of the population in the world is being infected. In fact, over 95% of the world population by the age of 40 is infected by EBV. So we are all infected, or nearly all infected. And once we are infected, we will not get rid of that infection, which means it will be a lifelong infection. So our immune system, again, through millions of years of evolution, has learned how to keep that infection at bay, how to control it, but at the same time, not to completely get rid of it. Now, there are some situations where our immune system will be compromised or will be depressed that will lead to the ability for the virus then to have a more active phase, not to be so much under control. And that happens, for example, in post-transplant patients where you need, when you transplant a solid organ or bone marrow to a patient, you need to give an immunosuppressive treatment to this patient so they don't reject the graft. And in that case, that means that the immune system being depressed, being suppressed, there is some reactivation of EBV, either from the patient or from the donor, that will lead to lymphoma, which is a cancer of the B cells that are infected by EBV. So it'll be an EBV positive lymphoma. And that's a disease we are treated when we talk about post-transplant lymphoproliferative disorders. That's very deadly disease. Now, there are other situations, especially in autoimmune disease, where we believe that EBV infection is the trigger of the disease and also the driver of the progression of the disease. A very clear example for us is multiple sclerosis, a devastating disease that affects millions of people across the world, and for which for many years there have been this idea that maybe viral infection might be linked with MS. Now, since last year, with 2 landmark publications, one in Science, one in Nature Medicine, we know that it is indeed the case that EBV is the trigger and the driver of the disease. Let me tell you why. What the Science paper is telling us, following 10 million military personnel in the US for 20 years, is that you need to have an EBV infection to be able to develop MS. And there is this correlation, this causal aspect of EBV to MS, which is not the case with any other viruses. And in fact, once you get EBV, you have an increased risk of getting MS, which is a 32 times increase, which is much more than what smoking will do to lung cancer, which is only about 10 to 15 times. So that's a very significant risk. And in fact, it's necessary to have EBV infection, not symptoms of mononucleosis, but EBV infections to have MS starting to develop. Now, this being said, the question is, how could that be that link between a virus and an autoimmune disease? And the other publication, Nature Medicine, clearly shown that what's happening, and it was great work done by Stanford team led by Larry Steinman, is they find in MS patients antibodies that are cross-reacting between EBV, the virus that is infecting their B cells, and a brain protein called glial-CAM, which is in fact a protein involved in the myelin production that is really so essential, not only for nerve conduction, but also is the issue when you have MS, where you have this destruction of myelin that is leading to neurodegeneration. So they find that antibody, and what finding that antibody means, and finding that it's cross-reacting, it means that this gives a possible explanation for the causal relationship between EBV infection and MS, which is that there is a case of mistaken identity. We mean by that the immune system is trying to develop a response to the EBV infection, the latent infection, especially in B cells in the brain of these patients. But these antibodies, or the T cell they will try to develop, will in fact attack the brain protein and start to create a cascade of autoreactivity and autoimmunity against the brain protein. And that's clearly a landmark discovery because it gives an explanation on this link between the EBV infection and multiple sclerosis. And having these two papers now tells us that we have a clear evidence that multiple sclerosis is triggered by the EBV infection, latent infection, but is also driven in the progression of the disease by that infection. Hence the idea at Atara to develop a very specific targeted treatment of multiple sclerosis called ATA188, it's just a code name at this stage, that we have now in a phase 2 double-blind study versus placebo with a readout in October 23, so just in a few months, where we hope to show that using allogeneic T cells that are specific to the latent infection that exists in MS patients with EBV will allow to better control that infection and eliminate or at least control this infected B cell and plasma cell that are the driver of the progression of the disease. In doing so, we hope that we can improve disability in patients or stabilize these patients in a way that no other treatment, either approved or in development today, is achieving. So if we are right, that could be a very significant achievement for patients, for medicine, for the better understanding of multiple sclerosis, and very importantly, a way to completely change the paradigm of treatment. Today you talk to MS patients, especially progressive MS patients, they will tell you that they have no hope. In fact, they know that they have their disease, that no treatment today can stop the progression of the disease. The best treatment are just delaying by a few months the progression of the disease. And every morning when they wake up, they will be extremely worried when they see that something is not right in terms of the way they move, the way they think, the way they have their energy level and fatigue level. They always think, okay, is that just a bad day? Or is it the disease that is progressing and then there is no way back? And that's a terrible type of situation that they are in. And we need to help these patients. And that's why this type of very innovative approach to the treatment of multiple sclerosis, relying on the first ever potential targeted therapy for MS, is so exciting.
Oh, it sure is. And I certainly hope that everything, all the effort that's being put into it does in fact make a difference. That's change a lot of lives. Earlier in the call, we talked a little bit about, or you mentioned, and you'll have to forgive my American accent, I'm going to not do well with this name, but Pierre Fabre, which is the French-based healthcare company, and your partner regarding the approval of and the manufacturing of Ebvallo. So what I would love for you to do is talk us through that partnership and how are you working together as it applies to Ebvallo?
Yes, a couple of years ago, we decided that we will not commercialize Ebvallo ourselves in Europe because we are a small company based in California. We have really to focus on creating and developing transformative innovation for patients. And the commercial activity is very different activities that requires different of talent, resources, and so on. We could have done that, but we are worried about the lack of focus. We want to focus on creating and developing this potentially transformative treatment for patients. So we decided to look for a partner, and we ran a competitive process. Pierre Fabre, that French company, won it because they were really committed to bringing that type of therapy to patients. They were committing to going into ultra-rare disease, into oncology, and they are already in oncology. But also, they were not worried about the fact this was a cell therapy, and they didn't have any knowledge about cell therapy because they knew that Atara is really an expert in cell therapy and could really help them to be successful in commercializing Ebvallo in Europe. So we ourselves filed for approval, Atara. We got the approval in December, as you know, and now we've transferred the approval to Pierre Fabre. So they're going to be the one launching the product in Europe, and their team are working hard now to make sure that the product could be available when needed, as needed, to European patients. So we're very pleased with this partnership. They are truly committed. They really think patient first, which is something that is very important at Atara, is we always think about the patient and what can we do for one patient, two patients, 10 patients, hundreds of patients is the same thing. How can we focus our energy so we can bring that therapy that we know could be life-saving to the patient as rapidly as possible? We know that they are sharing the same philosophy of even one patient is important. And that's so crucial, especially in ultra-rare disease. We are treating with Ebvallo just the potential of few hundred patients in Europe, but these few hundred patients deserve to get access to the product. And our partner, Pierre Fabre, is very committed to that, and we are very thankful of having such a partner for European patients.
Good. Okay. All right. Thank you for explaining that. Now I want to talk a little bit about your novel cell therapy platform, which is leveraging the natural biology of EBV, T cells, with the immune system to fight EBV-driven diseases. So briefly talk us through that platform. Where are we at? Where are we going?
So our platform is, as you said, addressing EBV-associated disease, but not only. And what I mean by that is our first product, Ebvallo, tab-cel, that is approved in Europe, and we are developing it and talking to the FDA to get through the US filing and approval. The second product, ATA188, that is addressing multiple sclerosis with that landmark type of publication supporting us, and this very exciting double-blind phase 2 study that will read out in October 23. These are products that are developed to address EBV-associated disease. For the first one, tab-cel Ebvallo, EBV-associated cancer. The second one, ATA188, EBV-associated autoimmune disease like multiple sclerosis. So that's certainly of focus attention because they are the most advanced, and they are very clear goals for the company to bring that to filing, approval, and so on and so forth. Now, what we've done as well is to leverage this platform, which is enabling us to extract and manufacture EBV-specific T cells from healthy donors to make EBV-associated disease type of specific and targeted product. We can use the same platform to ask these T cells that are EBV-specific to do something else. And when I say something else, I mean by that we can ask them to target something else than EBV-infected B cells. For example, we can insert a chimeric antigen receptors, so making a CAR T, in that case an allogeneic CAR T, in maintaining the EBV TCR, so the fact that these cells initially were EBV-specific, they were T cells that are targeting EBV infection, but we gave them another target. And we introduced that chimeric antigen receptors so they can hunt and kill other type of infected cells, and in particular cells in cancer that are in fact abnormal due to the tumor being developed in the patients. So we have two examples. One is in liquid tumors where we are developing an allogeneic EBV CD19 CAR T. CD19 is a surface antigen that is extremely frequent on B cells, and that allows to address the type of leukemia or lymphoma that are related to CD19. And you know that the first CAR T, Kymriah, and others that I mentioned earlier, the autologous CAR T, are addressing that particular target. So here we have an allogeneic off-the-shelf CAR T that could address the same target, but we are developing that in optimizing all the features that allows better efficacy, better safety, and very importantly, durability of remission. Because all the other allogeneic approaches that have been pursued so far do not give durable remission. They wear off after a few months. In fact, the cells being allogeneic are being eliminated usually within a month. And that's what we are trying to address with a product that we're developing, which we believe will have more persistence, leading to more durable remission in these patients. So that's what we're doing, and we're very excited about that program that will go to the clinic this year. Now, the other program that I can mention is a program targeting solid tumors, which is really an area where cell therapy to date have not been able to show sufficient level of efficacy. And here we're developing an allogeneic EBV mesothelin CAR-T. And mesothelin is a well-known type of protein overexpressed in many solid tumors from, of course, mesothelioma, which is a very deadly cancer, but also other type of lung cancer, ovarian cancer. And recently there have been very exciting publication on ovarian cancer there and the possible activity of mesothelin CAR-T in ovarian cancer. So we are developing that still at preclinical stage. We'll bring that to the clinic at some stage, but that's very exciting to leverage our EBV T-cell platform in creating and developing these allogeneic CAR-Ts that could address different type of tumors, both solid and liquid tumors, depending on the target we give to this CAR-T in the insertion of these chimeric antigen receptors. So the beauty of that is that we are really leveraging the natural biology of the EBV T cells. We don't gene edit the EBV aspect of the cells. They are still having a TCR targeting EBV, but their main activity will be based on the chimeric antigen receptor that is added to these cells that will target either CD19 or mesothelin in the two examples I was giving.
Excellent, excellent. Well, you've provided a plethora of really, really solid and insightful information throughout this call. So I can't thank you enough. I feel as though not only was my goal to have you on to talk through the how and the why of the first allogeneic therapy ever approved, but also we just learned so much from top to bottom here. So I thank you. At the end of every episode, I do like to talk to my guests about who they are when they're not in the office or the lab. And so in my research on you and your background, it does seem, that you have a little bit of the wanderlust bug and that you like to travel the world. And so my question for you is, tell us some of maybe the top or your favorite places that you've ever been and why they top your list.
Yeah, it's a very difficult question to answer. I love people, I love places, I love moments that are really unique. And maybe I'll give you two examples. One is there is a small island in Japan called Naoshima Island. It's the interior sea. And that island is very small, but it's very unique in the world because it's a museum. It's a contemporary art museum that was created there by very wealthy individuals with the help of Tadao Ando, who is an amazing Japanese architect. And when you go to that island, it's very small. You don't just have a few hotels and guest house. One hotel in particular is an hotel which is just on the coast of this island and has amazing pieces of art when you love contemporary art. I mean, you are in this hotel, you get to your breakfast and you see Rothko in front of you, you see Rauschenberg in front of you. I mean, amazing pieces of art there. And at the same time, there is so much peace in that island that you just don't want to make an invoice. You just want to enjoy that and then walk around and find pieces of art in different places, on a pier, in a mountain. You suddenly see a sculpture. You suddenly see something that allows you to go beyond yourself and think differently. And the second example I'll give you is, for me, Hawaii is an amazing place, a magic place. And I remember a particular night on Mauna Kea, so the big volcano, the tallest one on the big island in Hawaii, where we were there with my wife at 3 a.m. with a crazy guy that was so passionate about stars. And we were watching all the different galaxies with this guy, and he was explaining us the different galaxies and stars and so on in the sky, because that's an amazing place to watch the stars and watch the skies. It's very high, it's very clear. There is no lights around you, so you can really see the sky. And then at the same time, you know that you are on a volcano, still a dormant one, but next volcano, Mauna Kea, has been active just 20 years ago. just a few years ago, even not 20 years ago. So you have this feeling that suddenly you are in connection with the sky and the galaxies and the universe, but you're also on a planet Earth, that is very fragile, that is a living organism in many ways that we need to protect. So this type of places, people, and moment and experience is really what I enjoy about traveling.
Oh, they are really rich experiences that you just explained. And I've never been to either one of those places, but I'm sold. And so thank you for that.
I'll give you all the details later on.
Yeah. Yeah, great. All right, listeners, that's all she wrote for this episode of Cell and Gene, the podcast. Thanks to Atara Bio's Pascal Touchon for his time and insight today. Pascal, this was wonderful. Thank you so much for everything today.
Thank you, Erin. Pleasure to be with you today.
Absolutely. And thank you, listeners, for tuning in. Visit us regularly at cellandgene.com. And that's where you can register for our e-newsletter and subscribe to and download this podcast. And we'll talk to you soon.